today. Today we'll be talking about accountability and ownership within the revenue cycle. Excuse me. Understanding that, first we understand the basics of what a revenue cycle is. And your revenue cycle should be everyone, I'm sorry, I'm losing my voice a little today, everyone who's involved in a patient encounter. So that would include your scheduling and registration staff over on the front end, and from there into the providers of service, whether it be a doctor, a mid-level nurse, a therapist, etc. Coding is also considered a front-end practice, and all of those pieces have to be in sync for the information to flow appropriately through your charge master, which then can convey that information over to the payer. So through the charge master over to the back end would be your charge data entry people, your billing and follow-up teams, customer service, cash posting, etc. Any intervention on the back end of the process that has to be taken in order to get a bill finalized and paid in full, all of that information should be communicated back to the front end for continuous process improvement. Anytime an intervention has to happen at the back end, billers have to touch things to clean them up for your scrubbers or clearinghouses. Maybe you have denials that have to be addressed by your follow-up team, customer service complaints, etc. All of those should be addressed not only as the issue that fixed the claim, but even back to that front end for continuous quality improvement. The idea being fix the problem, not just fixing the claim, so that you never have that intervention have to take place again. So looking at all of these pieces within the revenue cycle, we're going to look at accountability and ownership. Understanding that a lot of people who advance to leadership positions, whether it be a team lead, a supervisor, manager, et cetera, within a hospital or a physician setting, frequently they're promoted from within and they don't have necessarily any management training. So how to get that out to your people for them to be able to convey that accountability and ownership to their teams. One of the big issues that we face when we don't have good accountability and ownership is employee dissatisfaction. This stems from unclear responsibilities when those managers or supervisors don't convey clearly their expectations to their team. So they may have a lack of communication, inconsistent feedback. Lots of times things like that can be perceived as assessment based on personality, not ability, even when it's not necessarily the case. When somebody, for instance, is promoted from within and now they are the manager of the team they used to work with, they're managing their friends and their peers. And there can be that disconnect, that feeling among the team that they're being assessed by personalities, friends first, abilities second. And that leads to huge employee dissatisfaction and lack of communication throughout the team. So it's clear to develop concise and easily understandable goals and achievements, expectations for your team to kind of mitigate that employee dissatisfaction. Another dissatisfaction would be the lack of challenge. If people don't really understand that they can get more responsibility, be more a part of the solutions, then they may not feel challenged in their job. No opportunities for advancement. We see that a lot within small facilities where maybe the same people have been in management roles for years, sometimes decades, and there's no opportunity for your super users to advance. All of these issues with dissatisfaction result in low morale. Low morale can then affect your lack of revenue capture. If people don't care as much about their jobs because they're unhappy in their jobs, it's difficult to get them to go that extra mile to bring in all of your revenue and do the reconciliations necessary. And that in and of itself can drive compliance issues. So trying to address all of these employee dissatisfactions through having clear and easily obtainable expectations for accountability and ownership. Now the flip side of that is, what are your common drivers for satisfaction? People tend to think it's the amount of money people make. But interestingly enough, when surveys go out for employee satisfaction, the things at the top of the list tend to be things like they feel included in the process. They're part of a team, and they're respected as part of that team and appreciated as part of that team. These are the things that people tend to look at the most as far as employee satisfaction. Now, money and opportunities for advancement, et cetera, usually is in the top 10, but it's not the number one things. It tends to be toward the bottom of the top 10. So understanding the ways to keep your team motivated and performing is to have that feeling of inclusion, to give them clear and concise goals, expectations, and to have, believe it or not, accountability and ownership within the process. So how do we go about establishing these expectations so that people can have a clear role and, clear picture of what their role is within the facility? First of all, you need to develop an audit process. You need to have an understanding of what you want to measure and what your expectations are for those things. And so if you're going to set production, quality measures, et cetera, it's a good idea to ask for feedback from the team. You will, as managers and supervisors, have an idea of where you want to go, but the team can help you figure out how to get there. And the more input they have, the more they have ownership of the process because they then become part of the solution. So whether you're looking to increase or improve your customer service expectations, production and quality across all areas, ask for that feedback from the team and let them know where you want to go and how they think we can get there. Education and training opportunities have to be part of the process. So if they say they have these needs and they feel they could succeed if they were given these opportunities, you have to be able to provide those ones that are the most realistic within the team. Develop a comprehensive revenue cycle process. If you don't already have one, make sure that you have revenue cycle teams that are kind of respective of the services that you carry. The right people have to be in the room. Create a mission for the team that says our goals for improvement are these. Improve patient quality, improve production quality, et cetera, whatever your goals for that team are. Make sure that you have representative inclusion from that team. Every revenue cycle team should include somebody from registration. They are frequently drivers of errors, and if they don't know you're getting denials because of your registration process, they can't fix it. So it should have registration people. It should have department leaders, coding if it's a facility or medical department. You should have business office representation and customer service representation. Everybody who touches that patient encounter should be included in your revenue cycle process. So make sure you have the right people there and then ensure proper participation. You do this by setting out goals for each meeting. Make sure you take minutes. That whatever the expectation is, things that have to be completed for that particular meeting, those tasks get assigned to somebody. That's in the minutes. That person commits to what they plan to achieve between now and the next meeting, and that is also in the minutes. And that way you ensure proper participation. If people don't know what you expect of them, they can't then achieve it. And lots of times once people know it's in writing, it's being distributed to the group, they're more likely to meet their deadlines. So my recommendation would be to get your minutes out as quickly as possible after the meeting, and then maybe a few days before the next meeting, just as a reminder to people that they have tasks due. Now, so that's how you would set up your meeting, but in the individual segments throughout the revenue cycle, you need to set those clear and obtainable goals for each area. So do you have production goals by area? For instance, in clinical departments, is your expectation be that there be average patients per visit per modality? For instance, how many patients does PT see in a day? For registration, what are their copay collection rates? Is there total revenue capture per patient? So for instance, in radiology, if you have a department with CAT scans, if you're doing a with contrast exam, are you also billing for the contrast? And then infusion areas, if you're billing for administration, are you also billing for drugs and vice versa? You have expectations around average wait times for patients. And this will vary from one area to the other. A patient who is fully expecting to and not unhappy about maybe waiting an hour in the ER might be very unhappy about waiting 15 minutes in the lab. So what are your expectations in each clinical department, average expectation for wait time for patients? What is it now? Where do you want it to be? And how do you go about getting there? That would require including all of the users in that process and getting a commitment from them to do whatever is laid out in your process improvement plan. Within the business office, you may be looking at average encounters or super bills, charge slips, whatever you call them, entered per day for your data processing people. What's your average that you are now at average per day per hour, and where do you think you should be? And even though you should average this per day or per hour, you want to take that snapshot over, say, a month period. People understanding that they will come across, if they're doing the reconciliation process right, there'll be some things that slow them way down. And what you don't want your expectations to do is to set people up to have to choose between being on time or being correct. So if you take it over a large enough period of time, say a month, then they can take the time to handle those difficult situations and not worry about the correctness and the quality of it skewing their production. Now, so keeping things like that in mind, you would track it per day or per hour, but you would examine it and average it over a month period. The same thing would be for claims resolved per hours. This might be whether it's claims resolved from your scrubber or clearinghouse that get rejected back to the biller to be corrected and put through, or from your follow-up team, they maybe are denied, a portion of it is denied and has to be appealed, researched, appealed, and reprocessed. Average remits posted per day per hour for your cash posters, and average calls handled per day per hour for your customer service people. So looking at all of the areas within that business office, and first you have to start by tracking where they are now and then setting clear expectations about where you want to go, what you want your production to look like in the future. As we move into the next few weeks, we'll be talking a lot about ICD-10. Hopefully all of you by now realize that the expectation is ICD-10 will take much longer for each of these tasks that we're talking about today. So any production improvement we can have now, or quality improvement we can make now, we can bank that for the point when we get to ICD-10. So that if you're at production, you have full production for your FTEs now, and you maybe make a 20% improvement, that 20% will allow you to stay more on track when you get to ICD-10. So it's really an important time to be having these discussions and looking at these things. Once we set about and identify where we are now from production and where we want to go, you take that information and then establish clear and obtainable quality expectations. You know, you may not get from A to Z in one move. You might want to do things incrementally so that the team can build their skills and, you know, feel a little bit better about the progress. If you set a goal of from 0 to 100% in the first month and they only get to 50%, you're not giving opportunity for that celebration of improvement. So you want to make sure that the goals that you set are obtainable and are very clear and are applied equally within the team. So if you have a production goal, it should be the average of where you are now for all of your people, and it should be applied equally across the board. Ensure that once you start to establish these goals, that administration provides whatever you need to have that level of improvement, so that you have the backing of administration. If you need additional training, if you need some desktop management, etc., how are you going to go about getting that so that your team, the quality of your team can rise? When the teams start to see that you have supportive senior management or that you're asking for these things to build them up, that helps people get to a point of where they feel more part of the process and they feel respected by their supervisors. So again, it will help raise the quality in production just from that perspective. Quality expectations, even though there may be different expectations from out each group, they apply to your clinical interactions and to the revenue cycle component. In the clinical side, it may be that the provider documentation has to be more explicit for coders to be able to get to the right diagnosis codes, et cetera. Or it may be that nurses have to make sure they put their stop times in so that you can capture all administration services. And on the revenue cycle side, it might be that billers understand payer-specific policies. So we're going to get into that in a little bit in just a few moments. Once you set your expectations, you want to be able to communicate those expectations clearly and have a series of rewards and consequences. Now, rewards don't have to be raises. They don't have to be dollar cash rewards at the end of the auditing period. It can be anything from just posting the graphs and celebrate success. Could be maybe having a cake at the end of an audit period or something like that. And consequences have to be very, very clear. Whatever your internal policies are, they should be followed fairly and equitably across all lines. If the process for consequences is, a verbal warning, then a written warning, then a process improvement plan, maybe termination. Those consequences should be very clear to all of those people and the users that are in your system, and they should be applied equally across all product lines so that nobody does get that feeling that they're being evaluated based on personality, for instance, instead of quality. Once you identify the things that you want to improve upon, how you think you're going to get there, make sure you're offering training in the areas identified from the team feedback. If it can't be because it was either unrealistic or can't happen at this time, make sure that you acknowledge that you heard them, you made these attempts, and this is what you can do in return, but keeping them in as part of the process. So now we've established, we've done some auditing to get a snapshot of where we are now. We've established goals in terms of where we want to be. Now, how are we going to just break that down into pieces? So we're going to do quality benchmarks saying, we're going to get to 80% the first month, 90% the second month, 100% the third month, et cetera. Always want to be striving for 100%, particularly when you're in clinical, obviously in clinical interactions, but even from a revenue perspective. 99% of $100 million a year is $1 million. So kind of keeping in mind that anything less than 100% as a goal is unacceptable. Always you'll have these scenarios where somebody makes a mistake here or there, but the goal should be 100% eventually. You may have to benchmark it and take steps to get there, but the goal ultimately is that 100%. And you would communicate that expectation out to your team. So, I have been in situations where I've provided training to managers and I've come back 6 months later and, said, how are things going? And they said, well, they haven't changed anything. I can't get them to change anything. And how are you relaying this information? Well, I'm giving them a list of everything they did wrong. But you're not taking that next step. You have to be able to take that next step. This is where we went wrong. These are the things we need to do to improve, and these are the steps we're going to take. Person A, those are your responsibility. Person B, these are your responsibility. It has to be very, very clear as we go through this process, or otherwise, people may be hearing that they're doing something wrong all of the time, but they're not given any opportunity on how to make it right. So having to follow through with that clear communication of what we expect in order for things to get better. I'll give you an example of something that I have seen in more than one hospital in dealing with business offices. So when I look at their appeal process, what do you do when you get a denial? Well, I appeal it. How do you appeal it? I drop the notes to paper with a paper UB and send it out to them, to the payer. Okay, did you know that that's what they needed? Maybe all they needed was a correction to the claim, the units corrected, or some other thing. If the process is always a one-stop process, regardless of what the payer is asking you, then that's not going to fix all of them. So what do you do when you get a denial after you send them the bill and the notes? Well, I get the notes again and I send it back out again, changing nothing in the process, but expecting a different result. So that person needs additional training. They need to have the expectations communicated to them. They maybe need to be taught how to read a remit more appropriately and look at what that denial reason is. They may need some training on how to review the medical policies or the claims processing guidelines for that particular payer, so that once they get an idea from the remit what the payer wants, then they can then go out to the websites and get that supporting documentation to provide continuous quality improvement. So taking that next step, not just telling them what you want from them, but showing them how to get there. Develop objective audit mechanisms so that once we've said these are the changes we want to see, now how are we going to determine whether or not those changes have taken place? Many times when I go into hospitals and say, what are you getting for denial information? And I find that they may be getting the data, but they're not getting it in the format they need it. They're not getting a true audit mechanism. So they may be told that they get 10 denials per month, when what they really need to know is 10 denials for medical necessity from this payer for these reasons. If all of that information isn't being provided, because a full and complete audit was performed, then they don't have enough information to affect that process improvement. So how do we get there? By developing a process, by saying for instance, each denial, we will look at it from all of these things. Right? At the payer level, at the line item level, looking back to the medical policy, if it's a denial for medical necessity, looking back at the claims processing guidelines if it's something other than medical necessity, like a pre-authorization, et cetera. You would obviously take a completely different process improvement plan if you knew your denials were because you didn't obtain the proper authorization or any authorization for the service performed, than the process improvement path you would take if they were medical necessity denials. Making sure that you have that mechanism in place to clearly identify not only that something is wrong, but what is wrong and what needs to be done to correct it. Now, once you have all these pieces in place, you convey to the servicing department the nature of, for instance, these denials and what needs to be done to correct it. They're pre-authorization denials. We need to get authorizations more timely. And then evaluate that process for improvement. Did what we talked about fix it? If not, why? And kind of go through it and maybe repeat that audit again. Whether you got improvement or not, you want to repeat that audit because sometimes people tend to slip back into old habits if they're not reminded of what's important in the issue. So be consistent, apply all of the steps, make it clear what your expectations are, get that commitment for improvement, repeat the audits regularly, and be consistent with that process. We're going kind of department by department within your revenue cycle. Ancillary services such as lab, radiology, etc. Who within that department is responsible for the contents of your order entry dictionary? So if providers can order either electronically or through some other mechanism, who is responsible for maintaining that? Making it very, very clear, for instance, for radiology, if the exam, a CAT scan is being ordered with or without contrast or without then with contrast. So who's responsible for putting those pieces together? And is it complete so that if an exam is ordered with contrast, do you know to automatically bill that contrast, for instance? Within the department, whether it's lab, radiology, et cetera, who owns the charge master? Who is then responsible for taking those elements from the order entry dictionary and conveying them into CPT codes so that they can then be transferred to the payer system? And is there coding oversight of that process? Because sometimes departments have a really good handle on their charge master, but they may not necessarily be able to tell the differences between some very like services. For instance, if you have an order entry system or an order system for an OR service, let's say it's an endoscopy suite, and you know this place obviously does endoscopies, the CPT descriptions, you may have 30 or 40 CPTs that all begin with exactly the same description, something like upper GI endoscopy from esophagus through jejunum. This would be the way it would begin is through duodenum to jejunum for maybe 30, 40 codes. And that may be all that fits in your charge master is upper GI endoscopy to duodenum or something like that. Well, which of those codes is most appropriate for it? You might need coder involvement to help you get to that level. So who in the department owns the charge master, and do they have coding as a partner helping them refine it and make sure it's completely clear? You don't want to have a junk in, junk out scenario where they put it in and then somebody chooses it because it's all they see, but it's incorrect to begin with. Then looking at who reviews the orders to ensure proper revenue recognition. Is somebody then looking and saying, we did this with contrast, did we also bill the contrast? Or we ordered it without contrast and it got changed to a with contrast, was the authorization updated? So who's looking at that last check and balance piece as you're doing your revenue recognition process? Who within the department reconciles and ensures total revenue capture for electronic files? If you think your RAD and lab, for instance, or PTOT, you're sending a file including 80 patients that came to the lab, did the billing office actually receive all those 80 patients? Or did some reject, and do they know how to clean up those rejections? Do I have a check and balance there anywhere? If not, you need to get that instituted. Does the department, each of these departments, hold revenue cycle meetings? And again, are those meetings representative of their individual revenue cycle? Their denials may be the responsibility of someone else. So a lab's denial, for instance, may be the result of the ordering doc because he's ordering screening tests too soon. Or they may be the result of registration for identifying the incorrect patient or not capturing new insurance. Even though it's a lab result, or I'm sorry, a lab denial, you have to then research it back and say, where did this problem begin? And it's not up to the lab necessarily to fix it. It might be that first end user where the process started to fall down. So are all of these people present in the revenue cycle so that they can be part of the solution? If they don't know it's happened, they can't be part of the solution. I have participated in revenue cycle meetings where lots of issues that get addressed at the meeting, the right people are there and they affect change and things go great. But the one person who was not at the table month in and month out is registration. And yet registration is always on the top 10 issues. When we break it down for denials, it might be something like they can't ID patient or subscriber not found or policy is lapsed. And all of these would be on the registration, on the very front end user to capture those things. If they are not invited to this meeting, then they don't know their process is creating problems downstream. So making sure you have all of those representative inclusion within your revenue cycle. For each department within your ancillary services, who's providing your CCI assistance? This would be your correct coding initiatives. It's the modifiers that are assigned for certain code pairs. So all payers, well, most payers, I don't want to say 100%, not non-HIPAAs like MBA and workers' comp, but most payers require additional information for certain code pairs billed together. And that information is usually in the form of a modifier. So within your modalities, lab, RAD, PTOT, all of these places that require modifiers, who is appending that modifier? Is it the coder, the user, the biller? And is that person providing that modifier, do they have access to the right information to make a determination on the modifier, and are they properly trained? Lots of times I see that it's the billers doing it, appending modifiers. And when I ask them why they made that decision, I usually hear that the payer told them to get it paid, they need to append a modifier. Doesn't mean it was appropriate to append that modifier. It doesn't even mean you deserve to be paid for that line. Maybe something else is wrong, and that's why it hit the edit. So it should be those people who are providing CCI correct coding initiative modifiers have both all of the information they need to make the decision and the skills they need to make the decision. And if it's your biller, they probably aren't being given the correct tools or training to make those decisions. So taking a look at that process and putting it back in the hands probably of the coders where it should belong. Now, once you have the CCI audit process, edit process in place, are the decisions audited, and if so, by whom? Ideally, the best way to do it would be have coders responsible for appending the modifiers and having a representative number of them audited each month to determine accuracy. And coders would have to audit other coders. We would cross-audit within the department. CCI edits can be the most audited services performed. Medicare, RAC, they love to look at 25 modifiers and 59 modifiers for overuse. So if it's important that if you're using these a lot, for instance, that you have the right people making the right decisions. And again, getting that accountability and ownership by showing them what needs to be done and maybe getting the billers to a comfort level where I don't have all the pieces, so I'm going to stop doing it and I'm going to start pushing it back to the coders. And the coders understand what's needed as well. So department expectations, for instance, in the emergency room. If your emergency room is reporting facility charges or professional charges, on a paper encounter form, charge ticket, super bill, whatever you call it within your organization. That form should have an implementation date and a version number on it. And each of these areas should be responsible for ensuring that only the proper version of the encounter form is used. Sometimes encounters have to be updated, for instance, because codes have been deleted. And if you don't take all those older forms out of circulation, somebody can make copies of them, put them right back into circulation, and now you're risking denials from billing deleted codes. There have also been parts of revenue cycle where we look at the service analysis, that is to look at the utilization at the code level for all of the services that take place in a department. And I see some unexpected spike at some point in the revenue cycle. And I might take that back to a department and say, you know, you used to do this 3 or 4 times a month. Now you're doing it 50 times a month. What changed? The department says, well, nothing changed. We don't do that. I don't know why you're seeing it 50 times a month. And to take it actually right down to the floor level, to the people who are completing the encounter, and saying, what do you do when you check this box? I've found, believe it or not, more often than more than one occasion where they didn't know the encounter had been changed. And since they started in that department, they've always checked 3rd column, 5th from the bottom. And that's what they're still checking, even though it's a completely different code. So understanding that every time your encounter form has to change for one reason or another, that it's educated and communicated back to the users of that form, and that the old form is taken out of commission and only the new form is acceptable. And who would be responsible for that piece within the department? Looking again at just the emergency rooms, does the department fully complete their revenue capture responsibilities? So if one person is the infusion nurse in there, do they understand all of the pieces that might be necessary in order to capture those charges? Is there a schedule attached, or it wouldn't be a schedule per se in the emergency room, but a list of patients? So if you saw 40 patients, you know you sent charge tickets for 40 patients. Who within each area reviews, reconciles those patient encounters to determine total revenue capture? If the patient received an infusion or hydration, did you bill for the drug or the saline? If a patient was sent down for ancillary services, did you capture those charges? And likewise, if you bill for the administration, do you have the appropriate drug that was administered? There are some very easy checks and balances that can be put into process without necessarily being coders or having a coding oversight to it. If there's a professional component, did you bill the corresponding facility component? Nurses may not know, for instance, whether the provider did a simple or complex suture, whether it was a 4 millimeter or a 4 centimeter or 5 centimeter suture, but they will know something was done, and to then go compare it to Pro and maybe reconcile it that way. Within the emergency room are there regular revenue cycle meetings, and again, it has to be representative of their revenue cycle, everybody who could be part of their process. In the emergency room, often we see a status called left without being seen, and that would be for a patient. Maybe some services were ordered, but before they had an opportunity to see the provider, the patient was tired of waiting and left. So lab came in and drew their labs, but they never saw a provider. What is your policy within your facility for things like that? And is that policy clearly communicated to the users to either bill or not bill accordingly? And how is that tracked throughout your revenue cycle? It goes down to that your average wait time. If you're getting lots of left without being seen issues, you might want to look at your process and see if you can improve upon your wait time. But equal to that would be, are we following the policy? Whether it's to bill or not to bill, because we do follow-up on the back end, so it's okay to bill it, for instance. Or we don't do follow-up, the patient never gets those results, so don't bill it. Whatever your internal policies are, make sure that everybody has the understanding of those requirements. Does the department get feedback on denials? And again, if they don't know it's wrong, they can't fix it. So a nurse is being told each time that, for instance, an infusion has to be downcoded to a push because there were no stop times. Or maybe multiple initials were billed on an infusion when you can only bill one initial per day. If they're not given these guidelines, they can't affect change throughout, and you'll keep getting these denials over and over. So getting them accountable for the process requires you to let them know, first of all, what the expectation is, and then to give this feedback in form of the denials. Moving on to an injection or infusion room, again, if they have an encounter, super bill, et cetera, make sure they're on the most current form. If your drugs are billed via your paper encounter, has pharmacy reviewed the encounter to ensure proper identification of codes? Are you billing at the unit level of the HCPC assigned, or are you billing at the vial, unit level of the vial? So for instance, a very common drug in infusion areas would be Rocefin, ceftriaxone, given for usually cellulitis or other infections. It's a 250 milligram code, and it's usually a gram vial. So each time you do 1 gram vial, are you billing 1 unit for the vial, or are you billing 4 units, which would be more appropriate at the HCPC level? That's what would be correct. But if that information hasn't been conveyed, for instance, to that department, you may be missing a lot of revenue in terms of your pharmacy. So has pharmacy reviewed those billing codes to make sure they have identification is proper at the HCPC level, not the vial size level? Does the department fully complete their revenue capture responsibilities here? One thing I see very, very frequently in infusion rooms is the lack of a stop time. They note when they start an infusion, what the drug is, and what the method of infusion, push, etc. But if the stop time is not recorded, lots of times you cannot capture the whole revenue. If it was an infusion, no stop time, you have to down code it to a push, which pays about half as much. If it were hydration without a stop time, you can't bill anything at all, even the patient that was hydrated for 5 or 6 hours. So does the department even understand that as part of their revenue cycle responsibilities or revenue capture responsibilities? And so what kind of auditing and follow-up is done to keep them on track, to keep them reminded of this, how important these things are? In the infusion area, can the department prove that all patients are accounted for on a daily basis? If they're scheduled appointments and they're billing on a super bill, is a copy of the schedule sent with each batch so that it can be reconciled? I saw 10 patients, I have 10 encounters or charge tickets. Or I had 10 patients, I only have 9, now I need to reconcile at the patient level to see which one I'm missing. Is there a review process after that to reconcile and ensure total revenue for each patient? So I saw 10, I have 10, I know I have the right number, but do I have the total revenue? Am I doing this check and balance, saying I have administration, do I have a drug? I have a drug, do I have an administration? I know it was a Rocefin, which is usually given over an hour, but all I have is a start time. Can I go back and get that real time today so that I don't have to downcode it? Do you have a reconciliation process like that? And does the department understand that they're responsible for that process and they own that process? Our drug units, administration routes review this mission as part of this check and balance. And is the department providing training to other revenue cycle participants? So, for instance, is billing being asked to participate as a partner? Every time you see this drug, you should see these administration services, et cetera, so that they can check and balance on their end and feed it back if they identify an issue. Is this department getting feedback from the business office on denials? And if so, how are the denials resolved? Are they doing it on a fix the claim basis or a fix the problem basis? You always want to be looking for that fix the claim and then fix the problem so that we don't see the same thing day after day. If you have paper encounters, super bills, charge tickets within your facility, somebody has to data enter that into your billing system. So how is that data entry process measured? You have a set of guidelines that say, you know, a representative number of these will be audited for accurate data entry, 10% a month, 5% a week, whatever it may be. Looking for, accurate data entry. Did I enter 51001 straight catheter insertion, for instance, when I meant to enter 57010, which is, draining of a pelvic abscess, I think it is. So looking at those simple transpositions of numbers that mean completely different things. Am I accurate? Am I auditing these things for accuracy? Is there correct application of modifiers? If somebody's taking the time to give me the modifiers, are they being entered as part of the ticket? Simple thing is that they enter the front and not flip it over and see there are charges also on the back. If they're responsible for entering diagnosis codes, is that audited as well? Are they getting the right medical record number, or is part of what we're calling a registration error because they can't ID patient really because the charge data entry person put the wrong medical record number in? So looking at it from all of these things, are they reconciling the encounter to the schedule? Do we even have a process that requires the schedule to be attached to the batch of encounters and be reconciled before it's posted? Are they doing that drug administration reconciliation piece that we asked for back in the infusion room? We gave them the training, and now are they actually doing that? And is there appropriateness to procedure to diagnosis code? Now understand, these people are not coders. If the verbiage comes up and it's blatantly wrong, they can assist with that piece. But otherwise, you would not put that on your data entry team to have that responsibility. Looking at billing, billing should be measured for a knowledge of payer-specific guidelines. So they should be production but also quality. If you are the Blue Cross biller, you should know whether Blue Cross wants the HCPCS for screening code, CPT, or the diagnostic. Some payers don't want the HCPCS. They want to get diagnostic codes, whether it's screening or diagnostic. Other payers want you to differentiate between a screening service and a diagnostic service. So if you are the biller for a particular payer, you should know your payer guidelines. You should know your payer-specific guidelines with respect to revenue codes. For instance, Medicare might want a minor procedure revenue code 361 for a colonoscopy or an upper endoscopy, or for an upper endoscopy, say, where a commercial payer might want 750 revenue code saying this is a GI procedure. So understanding that at the payer-specific level, you would expect your billers to know that. If they don't, you would query them to make sure they knew it. If they don't, provide that training and have an expectation moving forward. Payer-specific billing requirements with respect to modifiers, with respect to units billed. Making sure that if they're responsible for that payer, they have that information. If you have a known problem that's been identified through revenue cycle, do they know how to accurately write a claim check or request a claim check to catch that problem moving forward? Those are all also responsible for your scrubbers, your clearinghouses. So is there timely resolution of resubmission of anything that kicks back? The process there would be biller will enter them into or release them to the clearinghouse. Anything that doesn't pass might reject back to the biller for resolution. Timely resolution doesn't mean just slap a modifier on it to get it through whether the modifier is appropriate or not. It's you maybe go back to the coder, get the right information and get it through timely. Not send it back to the coder and forget they have it and never follow up. So timely resolution has to be not only timely but correct. Do they know how to get these reports and accurately trend it for future training? Again, back to the revenue cycle. We're getting reports, we're seeing the number of denials at the payer level. That's perfect information to research, get to root cause, and take it back to revenue cycle, not only to fix the claim, but for process improvement. And as you go through these steps, you will be expecting a reduction of those particular claims by reason. We fixed this problem. We saw 10 of them this month. We should see 1 or 0 next month. So looking back at that reduction of the unsubmitted claims in the future for that reason, having an expectation that that improvement sticks. Your follow-up team may be the same people as billing, or they may be different people handling your appeals, et cetera. And they should be measured, again, for an understanding of payer policies, for the maintenance of a payer library. Lots of times when I go on site, I might be reading remits, teaching people how to read them and say, okay, this is what they're saying is wrong. Do you know what's right? And where can we get that information? And I'm taken back to a room where they might pull a huge volume off of a desk, and I see it's a 2008 guideline, and here we are at 2012. Ideally, you want all your people to get to a comfort level of getting this information online, setting their favorites, having a bookmarked library so they can quickly and easily get to the most current guideline available. Not walk, maybe 100 yards down or 50 feet down even, pull a volume off a shelf that's 6 months old, flip through the paper and find it, or 6 years old, and get the wrong information, not quite updated information. So having that information at their fingertips, if they don't have it, you need to get it for them, help them build their library, train them how to organize their favorites for effective use, etc. They should also be measured for timeliness of their appeal or the collected claim turnaround time. If they hit timely filing guidelines, every payer gives you 90 days or more now. So we should not be hitting timely filing guidelines. If we are, what is the root cause of that and how can it be corrected? Is it a corrected claim turnaround? So are we looking at the real reason for the denial and getting the right information out to them so that we can get an accurate and timely appeal? What's the success rate of appeals at the individual follow-up team members? So if one person has a 60% success rate, somebody else has a 10%, and somebody else has an 80%, what is that 80% person doing differently from the others? How can that be trended and educated back to the other users? Again, we're always looking for continuous quality improvement initiatives. Letting people be aware of where they are and where you need them to be so that they can get there. Keeping it very, very clear as we cross these lines. Customer service in your revenue cycle is usually the last person in the chain. The service has taken place, the bill has come through, the patient got their EOB, and then they call. And so thinking about customer service from the perspective of the facility, obviously it takes time, maybe it causes issues, but one important thing that I think everybody should give some thought to, is you think about patients that have come in, maybe really challenging patients with difficult problems, diagnoses, et cetera, and the facility or the provider could have treated that patient perfectly, saved their life, given them a cure they never thought they could have, et cetera, and then they get a bill they didn't expect because something went wrong. We did something wrong. The part of the facility made a mistake. They call customer service and they're treated rudely. They don't love you anymore for saving their life. Now they hate you because your customer service rep was mean to them. So it's a big part of your face to your community how your customer service calls are handled. How are you judging that and auditing that process, and what expectations are you setting for those people? Do you have call monitoring measures? Do you measure the knowledge and understanding of the billing notes of that person? Can they read the notes and answer your patient's questions effectively? Sometimes it might be somebody you referred the patient to they had a problem with. They're still going to call your team. So how are they going to get that information? Can they accurately interpret and communicate that information, or are they falling down there? Do we have dropped calls, patients who are either intentionally or hopefully unintentionally disconnected? Is there in customer service an adherence to HIPAA requirements? I have been in positions where I sit near customer service and I hear them talking clearly to the parent of an adult child giving information that should not be provided, even when that parent is still paying the bills. Even understanding that now parents can have their children on their insurance until they're 26 years old. Once they're 18, you cannot share that information with those parents without that person's permission. So keeping that understanding of HIPAA requirements through your customer service process. Do you have a policy and a monitoring and an audit of resolution of calls and required follow-up? If they say they're going to call back, do they call back with the answer? Are you looking at the notes that your customer service teams are putting into your billing system and auditing that process? Keep in mind, notes should be clear, concise, and accurate. They should never be an editorial. So I have, as part of this process, read notes where I've seen things like, this person was a real jerk, I hung up on them, if they call me back, don't put the call through to me. Something like that should never, ever, ever be in your billing notes, and yet I've seen it. I've also seen notes where people, well-meaning, but they tend to ramble. Well, she called, she asked this question, so I said, okay. And I gave her this answer. I told her where to look. And she asked me another question, so I said, okay. And I put her on hold, and I waited 15 minutes. And I found the answer, so I went back to her. So I said, okay, here's your answer. Do you have any more questions? She said, no. I said, okay. I've seen that sort of thing in notes. You want your teams to understand that their customer service notes are maybe discoverable. They can be forwarded to an attorney, for instance, if they're requested. And so under all circumstances, they should be clear, concise, and professional. If for certain circumstances it makes sense to provide them with some education and a template, go ahead and do that. If your policy is, understand that customer service is a really hard job. These people are getting yelled at frequently when they don't deserve it. If the process needs to be, get off the call, be respectful, get off the call, take a deep breath, take a minute to decompress before you put in your note, then that's what has to happen. But under no circumstances should it be editorialized or should it ramble. You know, it's never good to see a note in your system saying, this person calls back, don't put the call through to me, I hate them. And believe it or not, maybe not in those exact words, but I've seen that in notes. So keep bearing in mind that these things can happen. It's a really hard job. So looking at all of these areas of your revenue cycle, from registration through provider, through coding, through the charge master, billing, follow-up, customer service, etc., what strengths and weaknesses have we identified? Cradle to grading some patient processes. What things can we act on? And if we find those issues that can be addressed, what steps were taken to address the issues? Remember, accountability and ownership expects both things. Not only that you find the issues and you hold people accountable, but the expectation that somebody take ownership and actually resolve it. Once you go through that process, have best practices been identified? And if so, can they be shared with other departments? If you improved a process for ER registration, can that be shared with lab or clinic, etc.? Who else can benefit from those circumstances or those issues, and who can benefit from additional training? You know, we trained the nurses at stop time, but we're still not doing a really good job of capturing the drugs, for instance. How can we make that happen? And once we identify who can benefit from that initial training, how are we going to go about delivering that training, internally or externally? So you need to be specific about what your expectations are and take a look at your in-house skill sets. Can you identify a peer to provide that subject matter expertise? For instance, we talked a few minutes ago about, you know, looking at the denial rate. A person who had an 80% success rate, somebody else had a 60, and somebody else might have had a 10% success rate. How can that person with the high success rate be leveraged to provide information to those other team members? It may be that they can receive the information better from their own teammates versus somebody else that might intimidate them. So looking for that as an opportunity. Again, inviting feedback from the team, offering that support and encouragement as you go through these processes. And always having that carrot and stick approach. You're providing the support and the training, but you also have an understanding that there's some corrective action to be taken if these things don't, if that person doesn't take responsibility, is not accountable to the process, and doesn't come forward the way they need to. So it's a good idea to look at quality incentive programs that you might have available to you. And these don't have to be in the form of money, like I said before. One thing that I've done in the past is, you know, managing a big team in a big hospital, billing, follow-up, charge entry, et cetera. Coming to year end, I know I'm working my people really hard, putting high expectations on them. So the day after a close, I might have a trivia day where I have simple little inexpensive prizes randomly throughout the day, email out some work-related questions. Whoever gets the answer correct and first gets to choose a prize. And these were small prizes, you know, usually under $1. But people enjoyed the process. They enjoyed that camaraderie. And it really would make a big difference. So, you know, looking at how can you be inventive about your incentive programs to keep people engaged and happy, but not necessarily break your bank. And always be looking to repeat your process, repeat your audits, always be looking for some area of improvement as we go through it. So that's what we have about the accountability and ownership. We'll be using these tools and examples as we go into understanding what implementation tools and strategies we will need to achieve ICD-10 success. ICD-10 will touch every area of a patient-physician encounter in all practices across the board. So you will then have to be using these skills that you're developing in your revenue cycle meetings to draw these people in, get accountability, get ownership, and have each person do their task. And so hopefully some of the things we talked about today will help as you move into ICD-10 success as well. I don't see any questions on my board. Do we have an opportunity now? We have just a few minutes left if anybody does have any questions.
Yeah, and if anybody has any questions, either type them in the chat box or it's *# to unmute your phone lines as well. And thanks for the great presentation, Lori.
Oh, it's my pleasure. And if any questions come in, in the future, you have John's access information, you have mine, feel free to let us know.
Okay.
Okay, thank you so much.
And my email address is on this screen now. If anybody has any questions, I can forward them on to either John or Lori. And like Lori said, the next presentation is going to be next Wednesday. And Lori will be speaking on the next 2 upcoming Hub webinars on ICD-10. And if you haven't registered for those yet, you can follow the links on the screen to sign up for one or both of those upcoming webinars. Also on the screen is the link